And good evening, friends. So today we will discuss about the new topic, that is disorders of vein. So we know that our cardiovascular system, which comprises of blood vessels and heart. So the blood vessels, which comprise of arteries, veins and capillaries. So here we will discuss about the disorders of vein. So before that we will just go through the basic structure and functions of veins. So the veins, which are thinner walled and larger lumen than arteries, which allows them to hold a large volume of blood. So these vessels experience least pressure as they are farthest from the heart. So the veins are thinner walled and large lumens and than the arteries, and it has low pressure as they are farthest from the heart. So the vein has three layers, that is tunica intima, tunica media and tunica externa or tunica adventitia. So tunica intima, which is composed of simple squamous epithelium, and it is the innermost layer of the lumen. Next is tunica media. It is the middle layer which contains sheets of smooth muscles, and it is less than the arteries. Next is tunica externa or tunica adventitia, which is the outermost layer, and it is composed of connective tissues, and this is the predominant layer of the vein wall. So next is about the three mechanisms that help. So we know that the blood under veins is very low pressure, so therefore three mechanisms which helps the blood to move forward through these low pressure veins or vessels. So the three mechanism is mainly by one is valves. So the veins has valve which prevent the backflow of blood. So the valves are flaps, which is comprised of folds of tunica intima, and the valves are most abundant in the veins of limb. Next is muscular pump, the muscular pumping mechanism. So that is the contracting the skeletal muscles which press against the veins and forces blood through the one-way venous valve. Next is the respiratory pump or the respiratory mechanism. So there are pressure changes which is associated with the breathing. That is, at the beginning of inhalation, the pressure decreases in the thoracic cavity and increases in the abdominal cavity. So the abdominal veins are squeezed during inhalation, and the unequal pressure which creates the upward sucking effect and pulls the blood towards the heart. So these are the three mechanisms which helps to blood move forward through these low pressure veins. So next we will see the types of veins. So the veins are mainly deep veins, superficial veins and perforating veins. So the deep veins which lies below the deep fascia, and superficial veins means which lies outside the deep fascia and carries 10% of blood. So the superficial veins are mainly long saphenous vein and short saphenous vein, and deep vein we know that it below the deep fascia, and the deep veins are anterior and posterior tibial vein, peroneal vein, popliteal and femoral veins, and the perforating veins which passes through the deep fascia, joining the superficial to the deep system veins. So next is we'll see the basic functions of veins. So the veins we know which not only transporting the blood to the heart, and it acts as a reservoir of blood. Next, the semilunar walls of the veins which helps to the move blood back to the heart. So the next is the pooling of blood, which does not cause an increase in blood pressure because the veins has an ability to stretch. So the veins has the stretching capacity, so that helps the to avoid the blood pressure as the blood flows through the veins. So these are the three main functions of veins. So next we will see the conditions or the disorders related to vein. So first one is venous thrombosis. So venous thrombosis involves the formation of thrombus in association with the inflammation of vein. So venous thrombosis is the most common disorder of the veins, and it is classified either as superficial vein thrombosis or deep vein thrombosis. So superficial vein thrombosis, it is the formation of thrombus in superficial veins, and it is usually found in the greater or lesser subvenous vein. Deep vein thrombosis is which involves the thrombus formation within the deep veins, and it is mainly commonly seen in the iliac or femoral veins. Next is the another condition, that is venous thromboembolism. So venous thromboembolism, which is the preferred terminology and represent the spectrum of pathology, that is from DVT to the pulmonary embolism. So next we will see the etiology of this venous thromboembolism. So there are three factors which play a major role in this etiology of venous thrombosis, which is venous stasis, hypercoagulability of blood, and endothelial damage. So these three factors together known as Virchow triad. So why it is called Virchow triad means a former German physician, that is Rudolf Ludwig Karl Virchow, who was a German physician. He described these three factors, that is venous stasis, hypercoagulability of blood, and endothelial damage. So these are three critical factors and which is important in the development of venous thrombosis. So that's why these three factors are together known as Virchow triad. And the patient at a risk for development of this venous thromboembolism or usually has a predisposing condition to these three factors. So the next we will see the risk factors for venous thromboembolism. So under venous stasis, so normally the venous blood flow depends upon the action of muscles in the extremities and also the functional adequacy of venous wall. So the venous stasis occurs when the walls are become dysfunctional or the muscles of the extremities are inactive. So some factors or some conditions which may result in venous stasis, it may include advanced age, atrial fibrillation, bed rest, chronic heart failure, fractured leg or hip, and long trips without adequate exercise. Next, obesity and orthopedic surgery, pregnancy and postpartum period, prolonged immobility, spinal cord injury with limb paralysis, stroke, and varicose vein. So these all are the predisposing factors that leads to the venous stasis. Next is endothelial damage. So the damage to the endothelium of vein, which is caused by direct or indirect injury to the vessels. So it is mainly by abdominal and pelvic surgery, caustic or hypertonic IV drugs, fractures of pelvis, hip or leg, and history of previous venous thromboembolism, indwelling or peripherally inserted central venous catheter, IV drug abuse, and trauma. Next is hypercoagulability of blood. So the hypercoagulability of blood occurs in many disorders. It may include antiphospholipid antibody syndrome, antithrombin third deficiency, dehydration or malnutrition, elevated factor 7 or lipoprotein. Next, erythropoiesis stimulating drugs, high altitude, hormone therapy, hyperchromocysteinemia, cancer, nephrotic syndrome, and use of oral contraceptive, and especially women age greater than 35 years and who use tobacco are double risk for developing this hypercoagulability of blood. Next is polycythemia vera, pregnancy and postpartum period. Protein C deficiency, protein S deficiency, sepsis, severe anemias, and tobacco use. So these are the disorders which leads to the hypercoagulability of blood. So next we will see the pathophysiology of venous thromboembolism. So the virtue of triads are the three main etiological factors, how it is leads to the thrombus formation. So and that venous stasis, we know that it is mainly due to dysfunctional vein walls, inactive extremity muscles, and changes in the unidirectional blood flow. So these are the changes occurring in venous stasis and the endothelial damage. So endothelial damage leads to the release of clotting factors and activation of platelets. So the damaged endothelium which stimulates the platelet activation and starts the coagulation cascade. So this predisposes the patient to thrombus development. Next is blood hypercoagulability. So the blood hypercoagulability creates an imbalance in clotting mechanism and coagulation, and also increases the fibrin production. So these three factors that leads to the platelet aggregates. It's mainly in the cusps of the veins, and the clotting factors which also stimulated to produce fibrin, and the fibrin entraps the WBC, RBC and platelets, and that begins to adhere in the vein walls. So that leads to the thrombus formation or the blood clots formation. So the frequent sign of this thrombus formation is the cusps of the valve. So if a thrombus is detached from the vein walls, that is become embolus, and that flows through the venous circulation of the heart and lodges in the pulmonary circulation. So that leads to the pulmonary embolism. So when the thrombus is formation occurs, that leads to the clinical manifestations. So this is the pathophysiology of venous thromboembolism. So next we will see the clinical features of superficial vein thrombosis. So superficial vein thrombosis is usually seen in the superficial leg veins, and the clinical features include tenderness, itching, redness, warmth, pain, inflammation and induration along the course of superficial vein, and vein appears as palpable cord-like structure, and edema, which is rarely occurs. Edema may or may not be present. And the next is the complications. The complication of superficial thromboembolism is, if it is untreated, the clot may extend into the deeper veins and leads to the venous thromboembolism. So next is the diagnosis of this superficial thromboembolism, mainly by duplex ultrasound scan, so which is used to confirm the diagnosis and to rule out the closed extension to the deep veins. Next is about the management of this superficial thromboembolism. So management is mainly by administration of subcutaneous fundoparinax, so which is a synthetic anticoagulant, which is very useful for superficial vein thrombosis. And if the superficial vein thrombosis affects very short vein segment and it is near to the saphenofemoral junction, the anticoagulant therapy may not be necessary. The oral anesthetics can ease the symptoms. Next is use of graduated compression stockings or bandages. Use compression stockings and bandages. Next, elevate the affected limb above the level of heart. Next, apply topical anesthetics. Next is perform mild exercise such as walking. So this is about the superficial thromboembolism. Next we will see the venous thromboembolism. So what are the clinical features of venous thromboembolism? So the venous thromboembolism usually found in the deep veins of arms, that is axillary or subclavian veins, and in lungs it is mainly in femoral, and in pelvic region it's mainly thrombus formation in the iliac vein and vena cava, inferior vena cava, and pulmonary system. So the clinical features of venous thromboembolism mainly include the lower extremity venous thromboembolism may or may not have unilateral leg edema, pain, tenderness with palpation, dilated superficial veins, a sense of fullness in the thigh or calf, paresthesia, warm skin, erythema, and the systemic temperature which is greater than 100.4 Fahrenheit. And if the inferior vena cava is involved, the both legs may be edematous and cyanotic. And if the superior vena cava is involved, the similar symptoms which occurs in the arms, neck, back, and face. So these are the common clinical features of venous thromboembolism. Next, we will move on to the complications. So the complications of this venous thromboembolism include pulmonary embolism. Next is chronic thromboembolic pulmonary hypertension and post-thrombotic syndrome and phlegmatia cerula dolens. So these are the these are the four major complications of this venous thromboembolism. So the post-thrombotic syndrome. The pulmonary embolism means the embolus which lodges in the pulmonary arteries or the pulmonary circulation. So that leads to the pulmonary embolism. Next is chronic thromboembolic pulmonary hypertension. The pulmonary hypertension is due to the formation of thrombus or within the pulmonary veins or arteries. So that leads to the pulmonary hypertension. Next is post-thrombotic syndrome. It occurs in 20 to 50% of patients despite adequate anticoagulant therapy, and it is result from chronic inflammation and venous hypertension. And the symptoms mainly include pain, aching, fatigue, heaviness, sensation of swelling, cramps, pruritus, tingling, paresthesia, bursting pain with exercise, and venous claudication. So these all are the symptoms of post-thrombotic syndrome, and the severe post-thrombotic syndrome that results in venous ulceration. So next complication, that is which is the rare complication, that is phlegmatia cerula dolens. So it is the rare complication. It may develop in patients with advanced stages of cancer, and it also results from severe lower extremity venous thromboembolism that involves the major leg veins, causing near total occlusion of venous flow. So the patient typically experience sudden massive swelling, deep vein, and cyanosis of extremity. And if it is untreated, the venous obstruction causes arterial occlusion and gangrene formation occurs, and that requires amputation. So that's why it is the one of the serious or severe complication and the rare complication of this venous thromboembolism. So next is about the diagnostic studies. So then diagnostic study mainly include blood laboratory studies and non-invasive studies and invasive venous studies. So blood investigation mainly include that is bleeding and clotting studies. So bleeding time, platelet count, D-dimer test, fibrin monomer complex. So all these blood um, studies should be done in patient with venous thromboembolism. Next, non-invasive venous studies, which mainly include venous compression ultrasound. So venous compression ultrasound, which is usually done to evaluate the deep femoral popliteal and posterior tibial veins. Next is duplex ultrasound. So it is a combination of compression ultrasound with spectral and color flow Doppler. So the veins are examined for its compressibility and the intramural filling defects. Helps to determine the location and extent of thrombus formation. So that is useful test for diagnosis of venous thromboembolism. Next is invasive venous studies, which may include computed tomography, venography. So it uses spiral CT to evaluate the veins in the pelvis, thighs, and it may be performed after giving a injection of contrast material. It may be performed simultaneously with the CT angiography of pulmonary vessels for patient being evaluated for venous thromboembolism. So next is magnetic resonance venography. So it uses MRI with the specialized software to evaluate the blood flow through the veins. It can be done with or without contrast. So it is high accurate for pelvic and proximal veins, and it is less accurate for calf veins. So this MRI resonance venography helps to distinguish between acute and chronic thrombus. So next is last one is contrast venography or phlebogram. So the phlebogram, which uses X-ray determination of location and extent of clot using contrast media to outline the filling defects, and it also identifies the presence of collateral circulation. So it is one of the gold standard test for venous thromboembolism, diagnosis of venous thromboembolism, but currently it is rarely performed. So next we will move on to the management of venous thromboembolism. In that, venous thromboembolism prophylaxis and prevention. So early and aggressive mobilization is based on patient condition. So early and aggressive mobilization based on patient condition, that is the easiest and most cost effective method to decrease the venous thromboembolic risk. Next is patient on bed rest should change position at every 2 hours. Next is teach the patient to flex and extend their feet, knees and hips at least 2 to 4 hours while awake, unless contraindicated. And patient who can get out of bed need to be in chair for meals and walks at least 4 to 6 times per day. Next is early and frequent ambulation is sufficient prophylaxis for very low venous thromboembolism risk patients undergoing minor surgical procedures. Next is anticoagulation and mechanical prophylaxis, which are not recommended for acutely ill medical patients at low risk for venous thromboembolism. Next is venous thromboembolism prevention. So it can be achieved by using graduated compression stockings. So these are part of venous thromboembolism prevention in hospitalized patients, and properly fitted this compression stocking may reduce the risk for venous thromboembolism. So proper use fitting means the toe hole it should be under the toes, and the heel patch is over the heel, and the thigh gusset is on the inner thigh, and it is there are no wrinkles in the stockings, and it should not, so the stockings are not to be rolled down or cut or otherwise it is altered. So next is the knee length stocking, which seems to be effective as high length stockings in the prevention of this venous thromboembolism in surgical patient. Next is intermittent pneumatic compression device. So the intermittent pneumatic compression devices which uses inflatable sleeves or boots to compress the calf and thigh or foot and the ankle to improve the venous return. The sleeves apply external pressure by means of an electric pump. So the intermittent pneumatic compression devices may or may not be used along with the graduated compression stockings. So next is about the drug therapy. So drug therapy mainly include vitamin K antagonist. So vitamin K antagonist, these are oral anticoagulant for long-term or extended anticoagulation. So the main drug is warfarin. So the warfarin inhibits the activation of vitamin K dependent coagulation factor 2, factor 7, 9 and 10. So as well as the anticoagulant proteins, that is protein C and S. So the warfarin usually begins to take effect within 48 to 72 hours, and then it takes several more days to achieve the maximum effect. So before starting the warfarin therapy, we have to take a careful history and do not give the antiplatelets or NSAIDs with this warfarin drug, because it may increases the risk for bleeding. So next is thrombin inhibitors. So thrombin inhibitors are indirect thrombin inhibitors and direct thrombin inhibitors. So the indirect thrombin inhibitors, which is divided into two major classes, that is unfractionated heparin and low molecular weight heparin. So it affects both the intrinsic and common pathway of blood coagulation by way of plasma antithrombin. So the heparin, which can be given subcutaneously for venous thromboembolism prophylaxis or by continuous IV infusion for venous thromboembolism treatment. So heparin induced thrombocytopenia, that is HIT, so which is an one of the serious side effect of heparin. So it is an immune reaction to heparin. So it causes severe and sudden reduction in platelet count along with the paradoxical increase in venous or arterial thrombosis. So next is low molecular weight heparin. So low molecular weight heparin or enoxaparin, which is derived from the ultrafractionated heparin, they have more bioavailability and more predictable dose response. And it has fewer bleeding complications than the ultrafractionated heparin. So next is direct thrombin inhibitors. The next thrombin inhibitors, that is direct thrombin inhibitors, which are classified as hirudin derivatives or synthetic thrombin inhibitors. So the which can be used in patient with the heparin-induced thrombocytopenia and when the anticoagulation is still required. So in this case, we are using the direct thrombin inhibitors. So next is synthetic thrombin inhibitors, which is used in patient at risk for heparin-induced thrombocytopenia and used for venous thromboembolism prevention in joint replacement surgery. Next is factor 10A inhibitors. So the factor 10A inhibitor, which directly or indirectly producing rapid anticoagulation. This include fondaparinux, apixaban and edoxaban. So this fondaparinux, which is contraindicated in patient with a renal disease, severe renal disease, and it can be given subcutaneously. But the apixaban and edoxaban, which are the oral drugs. So the drugs anticoagulant activity, which can be measured by using anti-10A assays. So next and another treatment. So another thrombolytic therapy for this venous thromboembolism treatment, that is the catheter directed administration of thrombolytic drugs, that is urokinase, tissue plasminogen activator. So these are the thrombolytic drugs. So it can dissolve the clots and reduce the acute symptoms and improve the deep venous flow. So this is the another treatment option for patient with the thrombus, that is catheter directed administration of thrombolytic drugs. So next we will move on to the surgical therapies. So surgical therapies mainly include open venous thrombectomy. So it involves the removal of thrombus through the incision in the vein. Next is inferior vena cava interruption device. So inferior vena cava interruption device, which device can be placed percutaneously through the right femoral or right internal jugular veins. This filter device is opened and spokes to the penetrate the vessel's wall, and the filter acts as a sieve type device, which permitting the filtration of clot without interruption of blood flow. So next is another surgical technique or procedure, that is percutaneous endovascular interventional radiology procedure, which can be used along with the catheter directed thrombolytic therapy. So especially for severely symptomatic patients with the iliocaval or iliofemoral obstruction. So after iliofemoral interventional radiology, the anticoagulation therapy is recommended. Next is nursing management of patient with the venous thromboembolism. It may include assess the risk for venous thromboembolism and monitor the venous thromboembolism at risk patients, and teach a patient who are at risk for venous thromboembolism about the preventive measures such as increasing mobility, using graduated compression stockings and intermittent pneumatic compression device, and taking anticoagulant drugs. Next is assess the use of dietary supplements or herbs that may affect the coagulation status before start anticoagulant therapy. And also tell the patient to avoid the excessive amount of vitamin E and alcohol, and encourage proper hydration in order to prevent additional hypercoagulability of blood. Next is assess for complication of venous thromboembolism, including pulmonary embolism and chronic venous insufficiency, and teach the patient and caregiver about the clinical manifestations of pulmonary embolism, and provide discharge teaching about the use of graduated compression stockings, anticoagulant drugs, and diet and laboratory testing, and teach the safety precautions to prevent falls or other joint injuries that might result in bleeding, and teach the patient about the lifestyle measures to prevent venous thromboembolism, including leg exercise, ambulations, and avoidance of nicotine and oral contraceptives. Next is nursing interventions for patients taking anticoagulants. So we have to instruct the patient to avoid restrictive clothing and applying moisturizing lotion to the skin and use electric razors and perform physical care in gentle manner and tell them not to forcefully blow the nose and avoid removing or disturbing established clothes and avoid restraints if possible and use only soft padded restraints if needed and apply graduated compression stocking or intermittent pneumatic compression stocking and reposition the patient carefully at regular intervals. So these are the nursing intervention for patient taking anticoagulants. So nursing diagnosis and some blood coagulation tests which are essential to know the drug. So the drug should be monitored. The anticoagulant drug should be monitored by using blood coagulation test. It may include international normalized ratio INR ratio for vitamin K antagonist and activated partial thromboplastin time. APTT value should be monitored if patient is taking this unfractionated heparin heparin derivatives and also check the activated clotting time for unfractionated heparin and all if the patient is taking anti-factor 10A, so it can be measured by using anti-10A assays. So next is the nursing diagnosis related to this venous thromboembolism. It may include acute pain related to venous congestion, impaired venous return and inflammation, and ineffective health management related to lack of knowledge about disorder and its treatment. And next is risk for impaired skin integrity related to altered peripheral tissue perfusion and the risk for bleeding related to anticoagulant therapy and the risk for potential complication related to pulmonary embolism and dehydration and immobility. So these are the nursing diagnosis related to venous thromboembolism. So this is the first disorder, one of the major disorder related to vein, that is venous thrombosis. So next we will move on to the another disorder, that is one of the common and most familiar disorders of vein, that is varicose vein. So what is varicose vein? So varicose vein, which are the varicosities, which are dilated tortuous superficial veins commonly found in the subvenous venous system. So varicose vein is or varicosities are dilated. Dilated means that is 3 mm or larger in diameter. That is the dilated tortuous superficial veins which commonly found in the subvenous venous system. So its incidence, it is more common in males in India and it is found in left lower limb or more commonly involved, and it is found in long subvenous system and affected in 2/3 of the cases. Next is about the etiology of varicose vein. The etiology of varicose vein is multifactorial and the risk factors include family history of chronic venous disease, weakness of the vein structure, female gender, Hispanic ethnicity, tobacco use, increasing age, obesity, multiparity, and history of venous thromboembolism and venous obstruction resulting from extrinsic pressure by tumor, thrombophilia, phlebitis, and previous leg injury. So these are the etiology and the risk factors of varicose vein. Next is about the different types based on the etiology. So in that, first one is primary varicose vein or idiopathic, so which occurs due to a weakness of vein walls and which is more common in women. Next is secondary varicose vein, which result from direct injury, a previous venous thromboembolism or excessive vein distension, hormonal causes, and secondary varicose veins also occur in esophagus, vulva, spermaticodes, anorectal area, and abnormal arteriovenous connections. Next is congenital varicose vein. It results from the chromosomal defects which causes abnormal and development of the venous system. So next we will move on to the pathophysiology of this varicose vein. So the etiology or risk factors that leads to the changes in vein wall. So we have seen different risk factors, or we have seen that the etiology are multifactorial and different risk factors are there. So that leads to the changes in the vein wall, so which leads to the overstretching of veins. So we know that the veins have a property of stretching. So but here it leads to the overstretching of the veins, so that leads to increase in size of veins, but valve leaflets do not expand, so that leads to secondary valvular incompetence, that leads to the backflow of blood, so which ultimately leads to the pooling of blood and increased venous pressure, so that leads to the further dilation and venous distension, so that leads to the varicosity, that is development of varicose vein, varicosity, that is dilate tortuous veins. So this is the pathophysiology of varicose vein, that is the etiological factors leads to changes in vein wall, that leads to overstretching of veins, that is the increased size of the valves, but the valve leaflets are unaffected, and that leads to the secondary valvular incompetence and backflow of blood, so that leads to the pooling of blood and increased venous pressure, that leads to the further dilation and venous distension. It ultimately leads to the varicosity, and that is dilated tortuous veins, that is varicose vein. So next we will move on to the clinical features of varicose vein. The most common varicose vein symptoms that include heavy achy feeling or pain after prolonged standing or sitting, so which can be relieved by walking or limb elevation. And some patients feel pressure or complain of itchy, burning, tingling, throbbing, or clamp-like leg sensation, and swelling, restless, or tired legs. Next is fatigue and nocturnal leg cramps. Next is ankle swelling towards evening. Next is the skin over the varicosities that may itch or pigmented. Eczema of the affected skin and venous ulceration. So these are the major clinical features of varicose vein, that is most common symptom, that is heavy achy feeling or pain of affected prolonged standing or sitting, which can be relieved by walking or limb elevation. And some patients may feel pressure or complaints of itchy, burning, tingling, and throbbing cramp-like leg sensation. And another symptoms, that is swelling and restless or tired legs. Next is fatigue or nocturnal leg cramps. Next is ankle swelling towards evening. And another features, that is skin over the varicosities, which may be itch and pigmented. And the next is eczema of the affected skin and venous ulceration. So these are the clinical features of varicose vein. So next we will move on to the diagnostic studies of varicose vein, that is mainly include local examinations. In local examination, The inspection. While doing the inspection, the varicosities may be either widespread or restricted to a single varix. So when such a single varix is situated at the saphenous opening, it is called saphena varix. So it must be distinguished from femoral hernia. So one can feel the characteristic thrill when the patient coughs. Such varix disappears when the patient lies down. When the varix is tapped with the finger, a fluid thrill may be obtained in the long saphenous vein lower down in the limb. So next is palpation. So while doing the palpation, the dilated veins are particularly palpated. The saphena varix is palpated and the presence of cough impulse is elicited. So next, some other few tests which are performed to know the details of varicose vein, including the site of incompetent perforators. So it includes different tests. First one is Brody-Trendelenburg test. So the Brody-Trendelenburg test, this test should be performed to determine the incompetency of the saphenofemoral valves and the other communicating system. So this test can be performed in two ways. In both methods, the patient should be first placed in a recumbent position and his legs are raised to empty the veins. So the saphenofemoral junction is now compressed with a thumb of the clinician and the patient is asked to stand up quickly. So in first method, the pressure is released if the varices fills very quickly by a column of blood from above. It indicates the incompetency of the saphenofemoral valve. So this is called positive Trendelenburg test. So to test the communicating system, the pressure is not released but maintained for about 1 minute. So the gradual filling of the veins during the periods, which indicates the incompetency of the communicating veins. So it is mostly situated on the medial side of the lower half of the leg and allowing the blood to flow from the deep to the superficial veins. So this is also considered as the positive Trendelenburg test. So this positive Trendelenburg test is an indication for surgery. So next test is tourniquet test. So tourniquet test, it can be called variant of Trendelenburg test. In this test, the tourniquet is tied around the thigh or the legs at different levels after the superficial veins have been made empty by raising the leg in a recumbent position. So the patient is now asked to stand up, and if the veins above the tourniquet fill up and those below the veins below the tourniquet, it will remain collapsed. So it indicates the presence of incompetent communicating vein above the tourniquet. Similarly, if the veins below the tourniquet which can filled rapidly whereas the above tourniquet remain empty, the incompetent communicating vein must be below the tourniquet. So this is by moving the tourniquet down the leg in steps 1. Moving the tourniquet down the legs that determine the position of incompetent communicating vein. Next is Pratt's test. So the Pratt test, which can be performed to know the position of leg perforators. Firstly, an elastic bandage which is applied from toes to the groin. So a tourniquet is then applied to the groin at the upper end of the elastic bandage. So this causes emptying of the varicose vein. So the tourniquet is kept in position and the elastic bandage is taken off. The same elastic bandage is now applied from the groin downward. So at this position of the perforator, a blowout or a visible varix can be seen. So this is marked with a skin pencil. So that is Brand's test. So next is Perthes test. So in this test, primarily intended to know whether the deep veins are normal or not. A tourniquet is tied around the upper part of the thigh, tight enough to prevent any reflux down the vein. So the patient is asked to walk quickly with the tourniquet in place, and if the communicating and deep veins are normal, the varicose vein will shrink, whereas if they are blocked, the varicose vein will be more distended. So that is the Perthes test. Perthes test. Next is Short's test. So Short's test, which can be done in long-standing case, if a tap is made on the long saphenous varicose vein in the lower part of the leg, an impulse can be felt in the saphenous venous opening with the other hand. So that is the Short's test. Next is Morris's test or cuff impulse test. So in this test, the limb is elevated to empty the veins, and the patient is asked to cuff forcibly, and the expansive impulses if felt in the long saphenofemoral valve is incompetence. Similarly, if the patient cuffs and in the saphenofemoral junction is incompetent, a bruit may be also heard on the auscultation. So next is Fagan's method to indicate the site of perforators. So the Fagan's in this test can be done in standing position. The places of excessive bulges within the varicosities are marked with a skin pencil. So the patient is lies down. Then the patient is lies down, and the affected limb should be elevated, and the heel is kept supported, and the examiner palpate along the line of the marked varicosities carefully, so that he can find a gap or small pit in the deep fascia, so which transmit the incompetent perforator. So this can be marked with the X, and this is the site of the perforator, and it should be tally or it should be correspond with the skin pencil mark of the venous bulge marked before. So next, another special investigations include venography, Doppler ultrasound, photoplethysmography, and duplex ultrasound scanning. So venography, that is an ascending venography, is performed by cannulating a vein in the foot and by injecting a contrast medium. So it is useful investigating procedure for suspended deep vein thrombosis, and if it in case of ultrasound is not available. Next is Doppler ultrasound, that is a valuable non-invasive tool which can be used to demonstrate the saphenofemoral or saphenopopletal reflux. Next is Doppler ultrasound. So Doppler ultrasound is a valuable non-invasive tool which can be used to demonstrate the saphenofemoral or saphenopopletal reflux. So next is duplex ultrasound imaging. So in this technique, high resolution beam mode imaging and Doppler ultrasound are used to obtain images of veins. So also measure the blood flow in these vessels. So direct visualization of vessels and anatomical structure and function about the vein can be made using this duplex ultrasound imaging. Next is about the complications of varicose vein. One more investigation, that is photoplethysmography. So here one probe is attached to the skin to assess the venous filling of the surface venules. So the filling of these vessels indicate the pressure of the superficial veins of the leg. So next we will move on to the complications of varicose vein. First one is thrombophlebitis. Thrombophlebitis is one of the complication. It means the inflammation of the superficial veins. In this case, the veins become red and feel like tender cords in the subcutaneous tissue. So next is pigmentation. Another complication, that is pigmentation. This is particularly seen in lower part of the leg. So brownish to black pigmentation is noticed. So this can be due to hemosiderin, which may be deposited from breakdown of RBC, so which have come out of the thin walls of the veins. So the hemosiderin, which is a product of RBC breakdown, which may be come out of the walls veins. Next is eczema or chronic dermatitis. So due to the extravasation and breaking down of RBC in the lower part of the leg, the skin may be itch and the patient scratches, which may be leads to the eczema formation. So alternatively, such eczema may occur following minor trauma or as an allergic manifestation resulting from various ointment applications. So the treatment mainly include the application of ointment containing zinc oxide or coal tar that can be used twice daily. So next is angle flare. So this can be another complication of the this varicose vein. Next is venous ulcer. So this results from more often from the deep vein thrombosis than from varicose vein. Next is hemorrhage. Which is from ruptured varicose vein, which is not common. So such hemorrhage may be externally or internally in the subcutaneous tissue. This may follow minor trauma, and the hemorrhage may be usually profuse. Next is periostitis. So periostitis, this occurs in case of long-standing case, particularly if a venous ulcer is formed over the medial surface of the tibia. Next is another complication, that is calcification, which occur occasionally seen in the walls of the vein, which are varicosed for many years. Next is equinus deformity. Equinus deformity is another complication of varicose vein. So the equinus deformity of the foot may be a result from long-standing varicosity. This is due to the bad practice of patient of walking on the toes for the relief of pain due to the varicosity. So these are the complications of varicose vein: thrombophlebitis, pigmentation, eczema, angle flare, venous ulcer, hemorrhage, periostitis, calcification and equinus deformity. So next is about the management. So management, that is first one is drug therapy. The venoactive drugs. So several natural and synthetic venoactive agents includes coumarins, flavonoids, which can be used to treat for varicose vein. So the therapeutic benefit of venoactive drug, that is pain relief, edema reduction, decreased leg cramping and restless leg. So these drugs are not approved by FDA, that is Food and Drug Administration in the US. And the surgical therapies include indications mainly positive Trendelenburg test, particularly saphenofemoral incompetencies, and contraindications include pregnancy, women taking contraceptive pills, thrombophlebitis. So the intervention mainly sclerotherapy. Sclerotherapy involves the direct IV injection of liquid or foam sclerosing substance that chemically ablates the treated veins. It can be used on telangiectasis, perforated veins, regular veins, varicose vein, which is 5 millimeter in diameter or smaller, or venous in case of venous malformations. Next is another surgical management, that is transcutaneous laser or light therapy. It used for patients with whom sclerotherapy is not contraindicated or has been ineffective. So next is another procedure, that is ligation. Ligation, ligation, that is in case of saphenofemoral incompetence. So the operation is performed under general anesthesia. An oblique incision is made below the groin creases, starting from femoral artery pulsation to 5 cm medially. So all the tributaries of long saphenous veins are ligated and divided. The long saphenous vein is now ligated flush with femoral vein, and particular care is taken to see that there is no intervening tributary of the long saphenous vein between the ligature and the saphenofemoral junction. So in this process, the superficial epigastric or the superficial circumflex iliac, the superficial deep external pudendal tributaries are ligated and divided. The long saphenous vein is now ligated distal to the flush ligature and is divided between the ligatures. So in this case, in case of saphenopopliteal incompetence, the ligature is applied at the short saphenous vein flush with popliteal vein and another ligature distal to it. Next is ligation with stripping. So the stripping operation is mainly performed in long saphenous veins, since incompetent perforating veins are hardly found in association with the short saphenous vein. Since stripping is this short saphenous vein cannot or not only long standing edema but may permanently damage the nerves. Next is endovenous ablation using thermal energy from radiofrequency or laser therapy for saphenous vein reflux. Next is multiple cosmetic phlebectomy. So in this technique, a beaver miniature blade, which is used to make tiny incision immediately over the vein. With a fine mosquito forceps, the vein is gently taken out of the surface vein when it is more generously grasped with larger forceps. So fine dissection may be required to free the varicose vein. The varicose vein is now resected by ligating both the ends. The skin incision is closed with either subcuticular stitches or with the steri strips to make the closure cosmetic. So next is about the nursing management of varicose vein. So it include tell the patient to avoid sitting or standing for longer periods and maintain ideal body weight and take precautions against injury to the extremities and avoid wearing constrictive clothing and walk daily. So and after vein ligation surgery, so encourage a patient to deep breathe, which promote venous return, and check the extremities regularly for color, movement and sensation, temperature, edema and quality of pulses. And some bruising or discoloration are normal. And elevate the leg 50 degree to limit the edema. and apply graduated compression stockings or bandages and remove them every 8 hours for short periods and they reapply. And long-term management of varicose vein, which is directed toward improving circulation and ulceration. Teach the patient about the proper use and care of custom-fitted graduated compression stocking, and the patient should be apply stockings in bed before rising in the morning, and emphasize the importance of periodic positioning of the legs above the heart. And the patient with the job requires long periods of standing or sitting needs to be frequently flex and extend her or his hips, legs and angles and change the position, and remind the patient to consult with their healthcare professional before taking any dietary or herbal supplements to avoid drug interactions. Next is about the nursing diagnosis. So nursing diagnosis mainly include acute pain related to ischemia and impaired skin integrity related to vascular insufficiency, and impaired physical mobility related to activity limitation due to pain. Next is imbalanced nutrition status less than body requirement related to increased metabolic needs, and disturbed body image related to varicose vein. So these all are the nursing diagnosis related to varicose vein.